Hi, I'm Dr. Adam Friedman, Professor and Chair of Dermatology at the GW School of Medicine and Health Sciences. One comorbidity we haven't really touched upon is also infection. And there is something really unique with atopic dermatitis where it's a love-hate relationship between pathogens and atopic dermatitis skin. So the unique immune milieu, the barrier dysfunction, but more notably, what's going on in the skin at the immunologic level sets the stage for, sadly, many different types of infection. The barrier dysfunction, but uniquely what's happening to the stratum corneum, you have a higher pH and the skin likes to be acidic, but also the microbiota, the microorganisms living on our skin, typically thrive and can maintain diversity at an acidic pH. In AD, at baseline, it's a basic pH, which messes with that diversity, but also fosters an environment that's great for Staph aureus, which is a common offender we think about when it comes to atopic dermatitis. But then when you think about the disruption of that diversity and when you have fewer players, that can also influence the local immune response, that inappropriate response, and can actually worsen inflammation. And there's a lot of really great data out of NIH from Heidi Kong's group, Elizabeth Bryce from Penn, showing that that decreased diversity actually precedes an atopic dermatitis flare. So we know that this inappropriate or really lack of diverse population of bacteria, there should be about 500 plus, when that diversity decreases, that can facilitate inflammation, forgetting the fact that inflammation can actually foster a dysbiotic picture. Now, that's just dysbiosis. That's inappropriate colonization, not enough players where they're supposed to be. Then we get to infection. So the armor is dysfunctional. The immune milieu suppresses the innate immune response. We know there's decreased antimicrobial peptides. These are the first line of defense, the ninjas, so to speak, of the immune system that literally chop up the pathogens trying to get through. That's not here. So these patients are higher risk for bacterial infections. We constantly talk about staph. In my talk here at RAD, I also mentioned strep. We cannot forget strep either, because strep is not going to be sensitive to all antibiotics we might think about when it comes to the management of bacterial infections. And then we have to think about viral infections too. Herpes loves itself some eczema, no question. Eczema herpeticum, it has the name for a reason, can be a life-threatening emergency. And in the setting of pregnancy, even more concerning both for the fetus as well as for the mother. But let's not also forget eczema coxsaceum, which is a robust response or a worsening of eczema in the setting of Coxsackie, hand-foot mouth disease, as well as molluscum dermatitis, which often portends a good prognosis in clearing molluscum, but having AD increases your risk for molluscum. So my focus for RAD is on the infection risk, but we also have to remember that at baseline, these patients have dysbiosis that can really tip the scales to worsen atopic derm, but also increase the risk for other infections. But the end all be all, really the more important thing about this comorbid disease or diseases is that if you treat the AD, that risk actually lessens and even goes away. So even just treating the disease and not the infection, there are several studies looking at topicals, even systemic therapies in a patient who has a superimposed infection. You don't even have to treat the infection. You treat atopic dermatitis, the infection can actually improve just from that alone. So that really speaks to the harm of not treating, the side effect of not treating. Treating AD lessens that infection risk.